Hi, I'm Scott Macpherson, and I'm here to give you some top tips on brief mental health assessment, and we're going to use a case study to understand this a bit better. David Robertson is a 50-year-old office worker who lives in an affluent area of town with his wife and their 2 children. David has no medical history of note, and he attends a primary care appointment to discuss stomach pains he's been experiencing recently. There are some stains on David's clothes, and a strong smell of body odour suggests that he hasn't been taking such good care of his personal hygiene recently. In conversation with you, David's speech is rather brief and monosyllabic, and he discloses that he thinks his family would be better off without him. What steps do you take to understand his situation better? You eliminate likely physical cause of his complaints. What steps do you take now to try to understand more about his presentation? Now you understand David's situation a bit more clearly. What are you going to do for him? To understand David's situation, you're going to want to do a detailed physical assessment. This should then be followed by some sensitive, open and honest questioning regarding your observations. For instance, he seems rather down. Ask him about that. He has stains on his clothes and there's a smell that you've noticed. You can ask him about these things too. Are things okay? What's going on? Is he coping? Does he want to talk about it confidentially? All these sort of questions help to build the therapeutic relationship with the patient. So, having eliminated physical causes for his complaints, the next thing we want to do is a risk assessment. We need to ask specifically about suicide and self-harm and consider high risk indicators, including specific questioning on suicide. Is he having thoughts about suicide? Does he intend to end his life? Is there a plan? Is there a means to carry out the plan? Does he have a time frame for carrying out the plan? And has he made any past suicide attempts? As you go down the list of these questions, the risk increases. So someone who's just having fleeting thoughts about suicide is less at risk than someone who's made a detailed plan and that person is less at risk than someone who has past suicide attempts. That's not to say that someone who is having fleeting thoughts about suicide won't commit suicide. They're still at risk. That's still an at-risk factor. What are the barriers to asking these questions? Sometimes we worry, feel uncomfortable or fearful that if we ask people these things, we're going to put the idea in their head. But it's our role to prevent suicide if possible. Talking about suicide or death doesn't put the idea in someone's head, nor increase the likelihood that they'll act on the idea. We need to take suicide and suicidal ideas, feelings, plans, seriously. Don't ignore or dismiss patients with suicidal thoughts as attention seekers. Sometimes these people are later found to have committed suicide. It's easy to view the patient within your own frame of reference. For instance, what's he got to be depressed about? He's got a good job, a loving family, big car, nice kids, etc. We judge their feelings and intentions accordingly. Stay with their feelings, not yours. Try not to steer them away from how they're feeling, with phrases like, "It's not that bad," or "I'm sure you'll feel better in the morning." This might make you feel better, but it won't make the patient feel better. Recognise that it's natural for a patient to express negative emotions at times of crisis. This can help you understand and accept the patient, even if anger or guilt is directed at you. Encourage the patient to talk openly about their thoughts, feelings, situation, plans and intentions, and help the patient problem solve those problems that can be changed. Ask them about self-harm. Evidence doesn't support the view that those who self-harm repeatedly are less likely to die by suicide. Those with self-harm history are 50 to 100 times more likely to die by suicide than the general population. Consider the following factors. Statistics or probability, for instance, age, gender. Clinical. These are dynamic and affect the mental state of the patient. For instance, a patient receiving command hallucinations telling them to harm themselves or someone else. Contextual factors. These are social and environmental factors like the loss of a key support mechanism, having the key worker off sick, being made homeless, experiencing relationship breakdown, the availability of ligature points, or being left alone with the means to commit suicide. We need to think about history in relation to risk. The greatest predictor of future behaviour is past behaviour. Consider the following factors when assessing risk. Recency. The more recent the incident relating to the risk, the more alert we need to be. Severity. The more severe the incident relating to the risk, the more alert we need to be. Frequency. The more frequent the incident relating to the risk has occurred in the past, the more alert we need to be. Consider also any pattern of incidents. For instance, self-harm occurring as a result of alcohol use. In assessing someone's mental health, we need to consider psychosocial factors. Stressors. Internal stressors like physical or mental illness or perceived loss. And/or external factors. Stressors like actual loss of money, status, relationship, etc. Coping skills. What helps the patient cope generally? Is there any substance misuse? Are there any other unhelpful coping strategies the patient uses? Have there been any changes in the patient's ability to cope recently? Relationships. Who are their key supports? Have there been any changes in their relationships recently, in the past? Cultural and spiritual factors. Consider whether their expressed thoughts or behaviours that seem odd might actually be normal in the context of the person's culture or spiritual beliefs. Occupational. Hobbies, interests, employment. Have there been any changes recently? Any changes in the enjoyment gained from these or the patient's engagement in these? We can consider the patient's mental state briefly, but don't worry too much about this. This will be done in more depth by a mental health professional. Consider the patient's appearance and behaviour, their attitude to the situation or the examiner. What's their motor behaviour like? Does it appear normal? Is there something odd about it? Patient's speech. Do you notice anything different about the rate, volume or quantity of the patient's speech? What are their mood and affect like? What about the form of thought? Notice the amount and rate of production of thoughts, continuity of thoughts, disturbance of language or meaning. Think about the content of the patient's thoughts. Does it seem delusional? Do they mention suicidality? What about the patient's perception? Are they experiencing hallucinations or other perceptual disturbances? We need to consider sensorium and cognition, level of consciousness, memory, orientation, concentration and abstract thinking. We can use standardised assessment tools to help us with these. And lastly, consider the patient's insight. Are they aware that there's a problem? So now we have a clearer understanding of David's situation. We're going to look to refer him on to specialists. The NICE guidelines tell us that if a person presents a high risk of suicide or potential harm to others, or a risk of significant self-neglect or severe functional impairment, we need to assess and manage the immediate problem first, and then refer to specialist services. Where appropriate, we need to make sure we inform families and carers. If a person presents considerable and immediate risk to themselves or others, refer them urgently to emergency services or specialist mental health services. If the person is assessed to be at risk of suicide, take into account toxicity and overdose if a drug is prescribed and potential interaction with other prescribed medication. If necessary, limit the amount available. Consider increasing the level of support, such as more frequent direct or telephone contact. And consider referral to specialist mental health services. You can write to the consultant for the acute service attached to the service, or make a referral to urgent referrals. In the local area, you can phone Royal Cornhill Hospital for advice. The NICE guidelines tell us that if a person with a common mental health disorder needs social, educational, or vocational support, we should consider informing them about self-help groups. However, this is not for patients with post-traumatic stress disorder. We need to consider support groups and other local and national resources like befriending or rehabilitation programs for people with moderate and severe disorders, and also educational and employment support services.